Thank you, Dr. Thacker, and thank you, SAGES, for allowing me to present today. So, like Dr. Thacker said, today we'll try to go through some of the nuts and bolts of how to make the business case for enhanced recovery. I do have disclosures, but they're not relevant, and I clearly forgot to put it in the talk. But anyway, this is my outline. We'll talk a little bit about value in health, what it really means to say value in healthcare, some of the available economic literature, some of the implementation costs, which I know can be somewhat relevant, as well as some of the outcomes that matter to the patient, as well as what ERAS does for organizational value. So, we'll go ahead and start that what the goal of healthcare delivery really is for us is obtaining the best outcomes. Unfortunately, or fortunately, depending on what your point of view is, now we kind of have to balance this in terms of cost of care. So very much the traditional way of looking at this is that cost and outcomes are thought of in silos. So we often try to minimize costs without really looking at outcomes, or trying to give the best outcomes, but kind of ignoring costs. But really, everything is very interrelated. And it's really important that we start thinking about that. And really the interjunction between cost and outcomes is what we call value. So Michael Porter, who is probably one of the more influential health economists out there from Harvard Business School, back in 2010 published a series of editorials in the New England Journal of Medicine. And he defined value in healthcare as the attainment of the best outcomes that matter to the patient at the lower cost. Now, implied with this definition is what a valuable intervention. It's not necessarily only better outcomes at lower cost, which is obviously kind of a little bit the holy grail, but if you have better outcomes at the same cost, or the same outcomes at lower cost, really these are what we consider as valuable interventions. And one important thing is that merely just lowering costs while ignoring everything else does not equate into higher value, because if it costs less, but you also do less well, then you're not really kind of helping anyone at this point. So, I'm not going to go into really the nuts and bolts of enhanced recovery themselves. We're all here. We all know that what the benefits of enhanced recovery can do. But, some of the elements of ERAS that really help improve value is that it does decrease and eliminate a lot of the interventions that provide no benefit. Pretty much all of ERAS is providing interventions that are both effective and most of the time decrease costs, and every once in a while for interventions that may be associated with increased costs, it's important that we assess their cost effectiveness before we widely implement. And there's a bit of you can't see, I don't know how well this projects online, but all this to say is that and this is about 8 years ago, so this may or may not be a little bit outdated, but when we surveyed GI surgeons in terms of their practice patterns, and this was a study out of Case Western, they showed that still in not that long, what did I just do? Okay, not that long ago, you can see that there is still about 40% of people who are using routine NG tubes, and when you look at when people were being fed, it really isn't that quickly after surgery, which is what enhanced recovery is really kind of all about. So all to say is that, part of improving value is not only kind of doing the right thing, but stop doing the wrong thing too. So that's quite important to keep in mind. Again, there's a lot of data, mostly in colorectal, but as we kind of get more, as we study enhanced recovery and other procedures, we show that there is significant decreases in length of stay. So, traditionally we do think of length of stay as the main driver of cost. So already here we see here, when you look at the meta-analysis of all the available and randomized trials up to 2013, there's about a mean 2.5 day decrease in length of stay. So, if you kind of look at this and you're just like, all right, why are we even talking about it? Is it even a question that enhanced recovery would result in lower costs? And the way I kind of look, you got to really look at your own practice environment. So this is the cost of an average hospital stay. So you can see that in the United States, it's about 4 to 5 times more than in Canada and in the UK. And when you look at what a 2.5-day decrease in length of stay will translate into in the United States, obviously here you have $4,500, in Canada about 15, and the UK about 700 pounds, which I'll be honest, I'm not sure how much the pound is worth anymore right now. So, but all to say is that some of the kind of tail end of the admission that really are the ones that we're saving in enhanced recovery, those are not really the ones that are most resource intensive, so they're the ones that don't necessarily contribute to the high resource utilization, high cost. This is a really old study, but it kind of just goes to show here that really the last couple of days, sorry, I just like pointed the laser in your eye there. The last couple of days really do not contribute all that much to the cost of care. What we do know is that complications are expensive. So ideally what we should be focusing on is trying to minimize or decrease our complications. We're just gonna go through many of these studies all showing that the more complications you have, the more money you have, the more it costs, and the longer the stay in hospital, which is, I think, no surprise to anybody. One of the more expensive ones tend to be respiratory, infectious, cardiovascular, and thromboembolic, which are associated with significant costs. But luckily, the enhanced recovery, through many of the meta-analysis, have shown that we do have a reduction in overall complications. Although, as you can see kind of from the forest plot, individually, a lot of the randomized trials have not in and of themselves shown that there is a difference between conventional care, however you want to define that, and enhanced recovery. So what does this actually translate to in terms of the economic literature? So we performed a systematic review a couple years ago looking at all of the economic evaluations of enhanced recovery, specifically within colorectal, and at that time there were 10 studies. Since then there have been several others that have been published, but you can see that in terms of the American studies, they're the ones that tended to at least report cost savings in favor of enhanced recovery for some of the reasons that I talked about earlier, the different costs of care. There are several new ones. Dr. Thacker is the author of one of the newer ones, which again also does show lower costs in favor of enhanced recovery. But when you start looking at the European or the non-American studies, this is where it's not super obvious that enhanced recovery is associated with lower costs. Although it must be said that the economic literature at that time really wasn't that methodologically robust. When we did our own study at McGill comparing enhanced recovery versus conventional perioperative care, and particularly we did a cost effectiveness analysis, you can see here that from an institutional perspective, the difference did not reach statistical significance, although once you start tacking on out-of-hospital costs as well as societal costs, this is where there is largely in favor of enhanced recovery. And one of the reasons why we really saw no difference in institutional costs is that part of it is that the days saved, again, were not really that resource intensive, as well as the complications in our enhanced recovery did not really decrease. And again, we know that complications being the main cost driver. When you look at non-colorectal enhanced recovery, this is kind of several of the meta-analysis because it would take days and days to kind of go through every single study, but generally the weighted literature suggests that enhanced recovery is cost effective or at least associated with lower costs. One of the important things that a lot of these studies, however, do not incorporate are some of the implementation costs. As we will hear, I think, in the next talk, or in others, there are resources that have to be devoted to setting up and maintaining an enhanced recovery pathway. When we look at our own experience at the MUHC, we have something called the Surgical Recovery Program. The PRE is the French part of it, but basically we have a full-time enhanced recovery nurse coordinator And as well, there are certain opportunity costs to the physicians, allied health professionals that make up this meeting, which usually occurs about 2 to 3 times per month, as well as some of the costs of developing some of the patient education material. So in over a 1-year period, it's about $110,000. Now that seems like quite a lot, but you kind of got to think that these are amortized over a large number of patients. At the MUHC, our surgical recovery program does not only develop enhanced recovery for colorectal. We've at the time when we did the study, we had an upper GI resection, enhanced recovery, pulmonary resection, prostatectomy, as well as colorectal. So over a 1-year period, there are 708 patients that were managed by enhanced recovery that were with protocols developed through our steering committee, and really it ends up being quite a negligible cost per patient. And when you think that, at least in pulmonary resection and esophagectomy, at our institution, these enhanced recovery was associated with significantly lower costs. So already the cost savings associated with enhanced recovery really outweighed or paid for the implementation costs. When you look at, from an American point of view, this is a study by Elizabeth Wick when she was still at Hopkins. And basically, she showed relatively similar cost to as some of the data that we have. So from a 1-year implementation cost, around $110,000. Obviously, the higher number of ERAS cases that you do, the costs tend to be a little bit higher just because of the more resources that have to be the more resources that have to be devoted to maintaining this program, but the per patient costs are still relatively negligible. Now, again, in their own experience, they were able to show that despite the approximate $1,000 extra per patient that were required for maintenance and implementation costs, this was still associated with significant cost savings over a 1-year period. And this is not just $634, but $634,000. One of the things I'll touch upon a little bit, but you already hear a really great talk from Dr. Peterson earlier about patient-reported outcomes. But again, I want to emphasize that value is not necessarily, when we talk about the outcomes in the value equation, it's outcomes that matter most to the patient. And a lot of the studies really don't incorporate the patient point of view or patient-reported outcomes. Everyone talks about morbidity, mortality, length of stay, but patients don't tend to care all that much about this, or really don't have a good idea of what that really means. When we did a systematic review of the outcomes used to evaluate enhanced recovery, we were able to, you can see that at that time, and this is all abdominal surgery, that patient-reported outcomes really were not reported in a lot of studies, so only 7 out of 38. And very, very few studies, less than half, reported outcomes in the post-discharge time period, which we all know, recovery doesn't stop at hospital discharge, but it continues in the weeks to months after surgery. We also did a qualitative study where we actually asked patients what they thought was the most important elements for their recovery process. And as well, we asked healthcare professionals the same question. And, surprisingly, there are a lot of things that healthcare professionals thought were really important, where things like pain, nausea, vomiting, which patients really didn't care or say were really all that important, because by the time they were discharged and at the 2-week, 4-week, 6-week periods, they don't tend to have a lot of these outcomes, these symptoms rather. And what they really are interested in are functional things that were important for their functional day-to-day living. So energy level and the ability to just move around without having discomfort were one of the things that patients said were really important to them, but really none of the healthcare professionals thought were important in the recovery process. And all this to say is that some of the instruments that we traditionally use to measure health-related quality of life for patient or recovery really don't kind of incorporate a lot of these important outcomes that patients think are that really matter to the patient. Although some of the new ones that have resulted from the POCI group have a little bit more validity evidence. Again, this is a newer systematic review done from our group as well, and we found 22 different patient-reported outcome measures that were used to measure recovery after major abdominal surgery, and the vast majority of them were of quite poor quality, and none of them met the minimum criteria from the ISPOR or the FDA in terms of patient-reported outcome measures. So all this is that we think about it a lot more right now, but we still don't have the right instruments to measure recovery after surgery from the patient's point of view. Although when you ask relatively simple things like when did you go back to work, did anyone have to take time off work to take care of you, we were able to show that enhanced recovery was associated with improved post-discharge outcomes, specifically lost days from work, as well as decreased caregiver time off work as well. And lastly, one thing that kind of is a bit of a byproduct to enhanced recovery is improvements in organizational culture. One of the main barriers to implementing enhanced recovery is the quote-unquote culture of the institution. So if people aren't receptive to it, then this may not kind of go anywhere. But it requires surgeon champions, anesthesia champions, nursing champions. You kind of just have to slowly chip away at it. And when you look at the hospitals that have successful enhanced recovery programs, they tend to have better organizational culture. They tend to have better cohesion. It's a little bit hard to kind of measure this. It's a little bit wishy-washy, but all this to say is that when you look at a lot of qualitative studies, this is one of the things that is highly cited or highly stated to be a very vital aspect of successful ERAS programs. And funny enough, and this is quite old. This is almost 20 years old now, but when the Veterans Affairs Committee first started looking at this, they were able to show that hospitals that had much better coordination between different surgical departments, anesthesia, and kind of better quote-unquote organizational culture, they tended to do better and have a lower mortality and morbidity compared to hospitals where everyone kind of hated each other. And a little bit of a newer thing, again, showing that on the x-axis, the kind of collaboration between tendings, and the more people collaborate, the lower the overall morbidity. So in summary, value in healthcare is defined as the attainment of the best outcomes that matter to the patient at the lowest cost. Enhanced recovery is high-value care, no matter which way you look at it. The implementation costs can be high, but these are largely offset by the savings that you can get from enhanced recovery. The outcomes that matter to the patient are there, but we're still pretty bad at measuring them. And finally, enhanced recovery may lead to improved organizational culture. Thank you.